Good morning, guys. Today we will be discussing about the initial placement or initial insertion appointment and then the post-insertion complaints or errors in the removable partial dentures. When we talk about the removable partial dentures, these are those partial dentures which are class-pretend dentures. So, first of all, let's see about the phases of removable partial denture treatment, which we have already discussed in our lecture on the construction of RPD, diagnosis and treatment plan, and the construction, laboratory procedures, etc., just for the revision. So, partial denture services may be conceptually divided into 6 phases: patient's education, diagnosis and treatment planning, surveying, mouth preparation, and then designing of the partial denture. Then comes third phase, adequate support for the distal extension cases. Not only distal extension cases, even for the anterior extension cases as well. Then comes establishment of the harmonious occlusion and its verification. The phase 5 is the initial placement procedure or the insertion time. And then phase 6 continues, that is the periodic recall. So initial placement and periodic recall for maintenance are two last but most important phases of the removable prosthetics therapy. As we already discussed about the phases, so initial placement procedures, these are the 5th phase of treatment. This is the stage when patient is given possession of the removable prosthesis. During acrylic processing, some minor occlusal discrepancies may occur. Hence, at this stage, occlusal refinement is required. The denture bases should also be perfected to fit the basal seat area. And patient, when they leave the dental clinic after getting their prosthesis, they should leave with post-insertion instructions. The dentist should be sure that patient has understood the instructions and is going to follow those instructions. Well, on the initial placement appointment, usually the prosthesis is quickly placed and the patient is dismissed with instructions to return when soreness or discomfort develops. But that is not a good idea. The reason is, if patient will come back with the soreness, then you are going to relieve the denture even more in order to relieve the patient from the pain. There is soreness and probably you will give them some more relief and you will grind the denture even more. So best practice is patients should not be dismissed until denture bases have been initially adjusted as required, occlusal discrepancies have been eliminated, and patient education procedures have been continued. Although it is true that patients should be somewhat accommodating to get acclimatized to their new dentures, but certain other factors also play important role. Like the dentist should be able to accept new prosthesis as something new in their oral environment. But apart from that, dentist's attitude is also very important. They should be keen in making the prosthesis comfortable on this initial placement and adjustment appointment. If they are not doing that, then probably denture is not going to be a very well working dentures in future. So, firstly, how well the patient has been informed of the mechanical and biological problems involved in fabrication and wearing of a removable prosthetic restoration, and how much confidence the patient has acquired in the excellence of the finished product. Knowing in advance that every step has been carefully planned and executed with skill, and having acquired confidence in both the dentist and the excellence of the prosthesis, the patient is better able to accept the adjustment period as a necessary but transient step in learning to wear the prosthesis. This confidence could be lost if the dentist does not take the insertion and post-insertion phases seriously for the success of the removable prosthesis treatment, as I have already mentioned. Adjustment. When we use this term adjustment, it has actually two areas to be dealt with when we are discussing this term in removable prosthodontics. Firstly, adjustment of the denture bearing area and occlusal surfaces of the denture made by the dentist at the time of initial placement and on subsequent appointments. The second one is the adjustment or accommodation by the patient, both psychologically and biologically, to the new prosthesis. They should be accepting it as something new in their mouth. After processing acrylic bases and before dentures are removed from the cast, the occlusion must be adjusted to a perfect occlusal relationship between opposing artificial dentition or between the artificial dentition and an opposing cast or a template. Denture bases must be finished to eliminate excess and perfect the contours of polished surfaces for the best functional and aesthetic results. Unfortunately, these lab procedures rarely eliminate the need for final adjustment in the mouth to perfect the fit of the prosthesis to the oral tissue. So final refinement is always carried in patient's mouth. Well, now the insertion of prosthesis time, that final step. In this final step of finishing procedures, it is necessary to produce a biologically acceptable prosthetic restoration. The sequential manner to perform this is adjustment of the bearing surfaces of the denture bases to be in harmony with the supporting soft tissue. Adjustment of the occlusion to accommodate the occlusal rests and other metal parts of the denture, and final adjustment of the occlusion on the artificial dentition to harmonize with natural occlusion in all mandibular positions. Always use a pressure indicator paste when you are having any tissue bearing prosthetic restoration at the time of insertion. The reason is it will tell you if your denture is having any issues. Maybe it is pinching the patient on their soft tissue somewhere, so it will be easily revealed. If you will just send the patient without adjustment at this time and you tell the patient to come back when it is going to hurt you, so as I told you that you will be over relieving the denture for a traumatized area to restore the patient's comfort, and that is going to be a nuisance in future, because over relieved area you cannot go to compensate for that unless you will do some relining or rebasing, or you are going to reconstruct the dentures. Adjustments to bearing surfaces of the denture bases. The pressure areas most commonly encountered in upper and lower dentures are, if we look at the mandibular arch, the lingual slope of the mandibular ridge in the premolar area, I will show you the picture, the mylohyoid ridge, the border extension into the retromylohyoid space, and the distobuccal border in the vicinity of the ascending ramus and the external oblique ridge. In maxillary arch, the inside of the buccal flange of the denture over the tuberosities, the border of the denture lying at the malar prominence, and the point at the pterygomaxillary notch where the denture may impinge on the pterygomandibular raphe or the pterygoid hamulus. So if we look at the mandibular arch, the lingual area, the slope which is lingual to the premolars, this area, then the mylohyoid ridge area, and then the retromolar area, as well as on the buccal side the just close to the distrobuccal area close to the ascending ramus. And when we look at the maxillary arch, we can see in the tuberosity region on the inner side, on the malar prominence area, and then on the fitting surfaces in the pterygomaxillary notches. Bony spicules or irregularities in the denture base also require specific relief. These may be found in either arch, irrespective of how good you have taken the impression, how good your other procedures are, but usually these problems are always there, and you have to do the fine tuning or fine refinement when you are inserting the denture in patient's mouth. An adequate time is required for the insertion appointment. The area that most often needs thinning is the distolingual flange of the mandibular denture. Here the denture flange should always be thinned during finishing and polishing of the denture base. Sublingually, the denture flange should be reproduced as recorded in the impression. It should not go laterally to the mylohyoid ridge. It should cover the mylohyoid ridge and should go under the tongue. So distal to the second molar, the flange should be trimmed somewhat thinner. When the denture is placed, the dentist should palpate this area to ascertain that a minimum of bulk exists that must be encountered by the side and base of the tongue. If this needs further reduction, it should be done and the denture repolished before the patient is dismissed. Now the occlusal interferences from the denture framework. Any occlusal interference from occlusal rests saying parts of the denture framework should have been eliminated before or during the establishment of occlusal relations during the construction of dentures. The denture framework should have been tried in the mouth before a final jaw relation is established, and before trying it in patient's mouth, it should be seated and removed on the master cast and to check if it is scratching the plaster on the master cast or not, and if the seating and removal is without any interferences, then try it in patient's mouth. Well, so if there are any interferences, they should have been detected and eliminated. Much of this need not occur if mouth preparations and the design of the removable partial denture framework are carried out with a specific treatment plan in mind. In any event, occlusal interference from the framework should not ordinarily require further adjustment at the time the finished denture is initially placed. If the dentist had sent an impression or cast of the patient's mouth to the laboratory and to receive a finished removable partial denture prosthesis without having tried the cast metal framework in the mouth is considered as a sheer negligence. In case of occlusal imbalance, expect either a tender abutment or sore spots on the denture bearing area. Well, and yes, keep in mind that usually questions are being asked about this thing, and we usually don't pay attention that occlusion is playing very vital role even in the removable partial dentures. Now come the adjustment of occlusion. So how to create the occlusion in harmony with the natural and artificial dentation. The final step in the adjustment of the removable partial denture at the time of initial placement is adjustment of the occlusion to harmonize with the natural occlusion in all mandibular excursions. When opposing removable partial dentures are placed concurrently, the adjustment of the occlusion will be similar as the adjustment of occlusion on complete dentures. In case there are more natural teeth occluding in any mandibular position, those teeth will influence mandibular movement to some extent. It is mandatory that the artificial dentition on the removable partial denture should be in harmony to the natural dentition in patient's mouth. And for this purpose, what we do, we use the remounting procedure just like we did in our complete dentures as well. Same process is being done. And here the impression we take, it is the pickup impression. We place the dentures in patient's mouth, take the impression, and when we are going to pick up the impression, the denture will come along with the impression in the hydrocolloid impression. And then we apply the separating media and we are going to pour the model, so that when we are going to take out the model from the impression, the dentures will be very well established its relationship with the cast. And then we use the antagonist dentition and take the fresh, we have already taken the fresh maxillomandibular record. We use those to mount the casts, and then we are going to refine the occlusion using the articulating paper or shim stock or anything else. Instructions to the patient. Finally, before the patient is dismissed, they should be made clear that they have a removable partial denture which requires recall visits for proper maintenance. It is not something that they don't need to come back. They have to come every 6 months for maintenance, at least if not maintenance, to check if there is a need for maintenance or not. Patients should be instructed in the proper placement and removal of the removable partial denture. Patients should be advised that some discomfort or minor annoyance might be experienced initially. To some extent, this may be caused by the bulk of the prosthesis to which the tongue must become accustomed. So, the initial problem, if patient is going to get their first denture, is with the tongue, because tongue does not like anything which was not there in the mouth, and is going to definitely get irritated and is going to have like kind of discomfort with the presence of something new in the mouth. Patients must be advised of the possibility of the development of soreness despite every attempt on the part of the dentist to prevent occurrence of this thing. But inadvertently, some of the discomfort and soreness is going to occur. That is why the first appointment is after 24 hours of the insertion. Phonetics could be a problem in the beginning. Most hindrances to normal speech will disappear within few days. Very few patients will also experience gagging in the beginning. Oral hygiene maintenance and denture hygiene maintenance is also mandatory. Well, very big question, should we sleep with our dentures, or the dentures should be kept in a container of water while we are sleeping? The opinion is divided on the question of whether or not a removable partial denture should be worn during sleep. Conditions should determine the advice given to the patient, although generally the tissue should be allowed to rest by removal of the denture at night. So most of the dentists, they have a consensus that dentures should be removed, but few of the dentists, they say no, it is okay if patient is maintaining the oral hygiene to leave the dentures in their mouth. The denture should be placed, if they are out, they should be placed in a container and covered with water to prevent its dehydration and subsequent dimensional changes. Dimensional changes are going to occur in the acrylic part. Periodic recall. Initial placement and adjustment of the prosthesis on the insertion appointment is not the end of treatment for the removable partial denture therapy. Periodic recall visits and re-evaluation of the patient is necessary for early recognition of any changes in the oral structures. It will allow steps to be taken to maintain the oral health. So it is not that you have just placed the dentures and you will kick your patient out. No, your patient is going to be your patient and is going to visit you every 3 to 6 months depending upon the requirement. So minimum a 6-month recall period is adequate for patients. More frequent evaluation may be required for few patients where some additional care would be required. We will discuss that. Patients rehabilitated with RPDs should be recalled the day after the insertion of the prosthesis, that is the first 24 hours appointment. If anything more than a minor tissue damage is observed, they should be seen in next 2 to 3 days to ensure the healing of the damaged tissue. Well, otherwise after 1 week, and then every 6 months. The patients who are susceptible to caries or having periodontal problems, they can be recalled more often, like maybe 3 months interval or so. The recall visits should be long enough to give the patient confidence that required adjustments will be provided, at least half an hour appointment. Now, instead of when the patient comes just to start looking in their mouth, that is not a good idea. Listen to them. Listen to the patient carefully before doing any intraoral examination. Intraoral examination should be performed in detail with and without the RPDs, even if no complaints exist afterward. It should be remembered that some minor tissue damages or premature occlusal contacts which are not perceived by the patient can be detected and going to be corrected by the clinician, and future pain and discomfort problems may be prevented. Well, the problems associated with wearing an RPD may be classified into 6 categories. Pain and discomfort related to soft tissues or remaining teeth, difficulty in seating or removing the removable partial dentures, lack of retention and stability, functional problems, aesthetic problems, compromised periodontal health and mucosal lesions. Pain and discomfort related to soft tissues or remaining teeth. Pain and discomfort may be associated with the remaining permanent teeth, soft tissues surrounding the denture base, or both, and are one of the most usually seen RPD post-insertion complaints. The areas of tissue trauma may be in the incisive papilla, hard palate, residual ridge crest, the peripheral borders of the RPDs, or the mucosa not covered by the RPDs like lips and cheeks, but sharp margins are damaging those areas. Overextension of the denture bases and pressures on the fragile tissues such as incisive papilla or occlusal prematurities are the main causes of these ulcerations. Well, at times, broken occlusal rest, or if the occlusal rest is not present, that could be another reason that denture is going to impinge on the soft tissue under the occlusal stress and going to create the generalized soreness. The ulcerations due to tissue trauma develop generally at the initial recall appointments and can be solved easily by relieving the denture base parts touching the pain area. In case of overextension, ill-fitting RPDs or acrylic irregularities, the areas can be identified by the aid of an indelible pencil or maybe a pressure indicating paste. The difficulties in seating or removal of an RPD are usually seen in the initial placement appointment, but this complaint may also appear after the RPD has been in use for some time. This complaint may be further classified into 3 categories: incomplete seating of a rest and clasp assembly on the related abutment, seating problems due to pronounced soft tissue undercuts, and patient-related factors. Now, first of all, we will see the incomplete seating of the rest and clasp assembly on the related abutment. Here we can see the rest is not properly seating on the occlusal surface, and here because of that the retentive arm is not properly going into the undercut area. It is not at the appropriate position. If the rest and clasp assembly is not fully seated on the abutment, it may apply non-axial forces or the orthodontic forces on the abutment tooth and may cause mobility or movement of the tooth. These forces may cause significant discomfort, tooth movement, or metallurgical fatigue of the clasp arm due to being active all the time. Chances are that occlusal rest is going to be fractured, or maybe the retentive arm, or both are going to get fractured. This may usually occur because of the design errors. If a proper path of insertion was not designated at the time of treatment planning, the RPD may not fully seat on the abutments. The guiding planes should be carefully examined, and if there is a minor incongruity, the RPD may seat after preparing the guiding planes. If it is not possible to seat the RPD by modifying the guiding planes, refabricating procedure may be the only solution. Seating problems due to pronounced soft tissue undercuts. When there are pronounced soft tissue undercuts and you find those during the initial surveying, then design accordingly so that your denture base is not going to impinge on the soft tissues and going to cause some irritation or ulceration in that area. These undercuts at times even hinder from the proper seating of the dentures as well. So soft tissue undercuts may create problems if any component of an RPD passes over them during insertion or removal of the prosthesis. These problems usually involve pain and discomfort due to injuries of these soft tissues. These soft tissue undercuts should be surgically corrected prior to definitive treatment, but if they appear after the treatment, the RPDs may be rebased, relined, or remade according to the extent of the surgical procedure. Patient-related factors. Patient-related factors may be inability to manipulate or distortion of the RPD after usage. Elderly RPD users may have some systemic neurological disorders which may hinder insertion or removal of some complicated RPT designs which may have rotational path of insertion or multiple paths of insertion. Distortion of the RPD may occur if the patient tries to tighten the RPD or uses the clasps while insertion and removal using their fingernails for that purpose. So maybe repeatedly doing that, they are going to either distort or fracture the clasp. So these distorted or fractured clasps can be replaced in the laboratory. Lack of retention and stability. Retention or stability loss of an RPD may originate from the following situations: broken clasps or loss of the precision attachments, decrease in the function of the clasps or precision attachments, overextended or underextended denture bases, deflective occlusal contacts. Retention or stability loss may be due to one or all of these situations. The clinician must examine the origin of the looseness and make the appropriate treatment. Repeated adjustments of the clasp may cause fatigue of the alloy and is going to lead to the fracture of the clasp. Here we can see a broken clasp. Broken clasps are usually due to fatigue of the RPD components because of over adjustment of the retentive arm. Here we can see that. Then comes decrease in the function of the clasps and precision attachment. Function of the clasp may decrease after some time of usage because of repeated insertion and removals. Caries, abrasion or erosion may also lead to loss in the efficiency of clasp. Here we can see distal caries, and definitely the efficiency of the clasp is compromised because of there is loss of the tooth material in this area. Clasps can be adjusted to regain retention in the undercut area, but repeatedly doing that, it is going to definitely cause the fatigue and clasps are going to get fractured. Overextended or underextended denture bases. An overextended denture base may cause the muscle and frena to dislodge the RPD, and an underextended denture base may affect stability. The RPD may not be stabilized under the lateral forces and may result in food entrapment in that area. Underextended. Overextended denture base areas should be corrected by using a laboratory burr, and the flange should be rounded thoroughly while it is being shortened. Underextended denture base of an RPD may be elongated by relining or rebasing with a suitable functional impression method. Well, if it is too short, then you have to reconstruct the dentures. Deflective occlusal contacts. Whenever there is deflective occlusal contact, definitely the impact is going to be in the underlying area, as well as dentures are not going to be stable and retentive. So deflective occlusal contacts usually affect the stability, the RPDs, and therefore should be eliminated. If the deflective occlusal contacts are minor, they may be removed by occlusal reshaping with the aid of articulating papers, but if they are gross, the artificial teeth may be changed following a new interocclusal record. If the RPD is a tooth-supported one, occlusal reshaping should be completed using intraoral methods, but if it is a distal extension RPD, the grinding procedures should be performed using remount procedures, which I have already mentioned about that, with the aid of an articulator. However, it should be emphasized that the final grinding procedures should be completed intraorally to compensate the resiliency of the supporting soft tissues with articulating papers having various thicknesses. Now the functional problems. Functional problems are classified into 5 categories like gagging, eating or chewing difficulties, phonetic problems, tongue or cheek biting, and food impaction or collection on the RPD borders. Gag reflex is very common and it occurs to most of the denture wearers in the beginning, but within a couple of days it is going to be okay. Gag reflex is a somatic response in which the body tries to abolish foreign bodies from the oral cavity by muscle contraction at the base of the tongue and the pharyngeal wall. Unstable or poorly retained RPDs, increased occlusal vertical dimension, overextension of the mandibular RPDs in the retromylohyoid space, and the overextension or too thick borders of the maxillary RPDs in the posterior regions can intrude the trigger zones and they cause gagging. Gagging may usually be observed as a problem of the first time, which I have already mentioned, RPD users, and mostly disappears after using the prosthesis for several days, but in certain cases it persists for longer. To correct the problem of overextensions, the posterior lingual and palatal borders should be shortened and thinned. Correction of the increased occlusal vertical dimension requires re-establishing of the appropriate occlusal vertical dimension and removing and rearranging the artificial teeth of the RPDs. Poor adaptation of the maxillary RPDs to the tissues because of faulty impressions may also produce gagging. If the denture base is acrylic, relining may be the solution of this problem, but if the denture base is metal like most of the cases, then RPD should be remade. Placement of the posterior denture teeth lingually may also restrict the tongue space and may induce gagging. So in that case, we have to rearrange the teeth or you have to remake the dentures. Eating or chewing difficulties or inefficiencies. Patients usually report chewing or eating problems before prosthodontic treatment. It should be underlined that these problems increase rapidly after treated with fixed partial dentures, but slowly after RPD treatment due to an adaptation period for the new prosthesis. Moreover, it has been shown that RPD treatment improves the ability to reduce the bolus particle size, but it is not able to fully restore the masticatory function, especially if it is a distal extension denture. Patients should be advised not to eat tough and sticky food during the early period of adjustment. The occlusal surfaces of the artificial teeth should be examined with an articulating paper, and the occlusal prematurities should be eliminated, or the artificial teeth of one or both sides should be reset where an occlusal adjustment is not adequate to overcome occlusal problems, or if some artificial teeth lack occluding the opposing arch. Difficulties may also be related to retention, stability, or the vertical dimension, and these factors should also be evaluated and corrected if it is necessary. Then comes the phonetic problems. Certain words would be difficult in the beginning for the patient to say. The reason is there is something new in the oral cavity. Probably the anterior teeth were missing and now the anterior teeth are present, so they have to get acclimatized to the new environment. Maybe the bulky palatal connector, etc., etc. So RPDs usually do not generate speech difficulties, but like the complete dentures, they do. But still there would be some chances. The location of the anterior teeth, especially on a maxillary RPD, should be corrected in order to allow the tongue and lips to work accurately. Changes in the contour of the anterior palate and occlusal vertical dimension may also show phonetic difficulties. Speech problems are usually seen in the first few days after the insertion of the RPDs, especially when the patient is a first-time denture wearer. If no improvement is achieved, then you have to alter the design, or maybe you have to rearrange the teeth, etc., etc. Additionally, it should be noted that since degenerative changes in auditory abilities exhibit difficulties to adapt to new prostheses in older patients, so adaptation is usually much easier to achieve in the younger patients. Tongue, lip, or cheek biting. Tongue, cheek, or lip biting are common complaints among patients receiving prosthodontic treatment, no matter it is complete denture or it is removable partial dentures. Patients bite their cheeks mostly because of inadequate posterior teeth horizontal overlap. To overcome this problem of insufficient overlap, the posterior teeth might be gently rounded and reduced in size buccally, or all the posterior teeth may be reduced buccally to move away from the soft tissues. However, reducing the artificial teeth size may reduce the chewing ability of the patients. In that case, the artificial teeth should be changed and should be rearranged. Patients who have lost their posterior teeth a long time ago and have never used the RPDs, their buccinator muscle drops down to the space between the edentulous residual ridge crest, and that may lead to cheek biting. But if they are going to get their RPDs, then within couple of weeks time, then their buccinator muscle is going to be trained again and they won't be cheek biting again. If the interocclusal space between the posterior denture bases of maxillary and mandibular RPDs is too small, again I am saying the reduced interocclusal space, the patient may bite his or her cheek. Grinding the acrylic bases to lengthen the space is the only solution in those situations. If teeth are arranged too lingually, tongue biting may be observed, and in case of anterior horizontal overlap, chances of lip biting may be present. Food impaction or collection on the RPD borders. Food impaction happens usually when the acrylic denture base is not well adapted to the abutment teeth. The reason is usually starting the prosthodontic treatment without properly restoring the abutment teeth. So restarting the treatment with proper planning, including the restoring the abutment teeth rather than relining the denture, is the most appropriate solution in these situations. If the food trap is due to an insufficient extended denture base, the solution may be relining. Food collection on the borders may occur in the case of poorly contoured or not well polished acrylic surfaces, or if the patient has a reduced salivary flow. Recontour and polish acrylic surfaces in case of lack of salivation. Properly address the problem. Metal components visible upon smiling or talking. Most common aesthetic problem. Or maxillary anterior flange is thick and obvious. It is very important to plan the RPD before starting the treatment according to the aesthetic zone of the patient. Inappropriate axial inclination of the artificial tooth position, discoloration or abrasion of the acrylic teeth, and too low or too high occlusal plane may also add to the aesthetic problems. These problems may be solved by replacing the artificial teeth with new ones. Compromised periodontal health and mucosal lesions. RPDs affect the microbial ecosystem onto both the remaining teeth and the oral mucosa because of plaque accumulation and hygienic maintenance. In some patients, there is proliferation of spirochetes and fusobacteria upsurges with the presence of RPDs. Few patients can develop denture stomatitis as well. It could be with or without proliferation of the fungal infection, or maybe super added bacterial infection. Good oral hygiene, proper RPD design, and most prominently regular recall for RPD users are essential for controlling and preventing the occurrence of periodontal diseases or stomatitis. Reasons for failure of removable partial dentures. Reasons for the failure according to McCracken are categorized as improper diagnosis and treatment planning, inadequate improper mouth preparation procedures, improper design of the framework, faulty laboratory procedures, improper support for denture bases, improper planning of occlusion, and a lack in dentist-patient relationship. So firstly, diagnosis and treatment planning. If there is inadequate diagnosis, dentist was not able to diagnose the case completely and understand the requirements of the patient, probably it is going to end up at a very bad taste and patient is not going to be satisfied. So we consider it as a failure of the treatment. Failure to use a surveyor or to use a surveyor properly during the treatment planning. Either the surveyor was not used at all or maybe not used properly to ascertain the undercut areas and height of contour, or the dentist failed to tripod the cast after surveying and now they are totally lost what they designed and what was the actual position. So that is again going to create a big mess. Mouth preparation procedures. Failure to properly sequence the mouth preparation procedures, like occlusal rest seats are prepared before preparing the guide planes, and now you are going to prepare the guide planes and half of the occlusal rest seat area would be gone. Inadequate mouth preparations usually resulting from insufficient planning of the design of the partial denture or failure to determine that mouth preparations have been properly accomplished. Then failure to return supporting tissue to optimum health before impression procedures are performed. Inadequate impressions of hard and soft tissues. Design of the framework. Failure to use properly located and the size of the rests, both in the direct and indirect retainers, or fail to provide the indirect retention. If there are no rests in the direct retainers, so what is going to happen? Under the occlusal load, the dentures are going to impinge on the mucosa. In case if the indirect retainers are missing, then denture is going to get dislodged, tissue away movement, and the denture is going to get rotated on its axis of rotation or on the fulcrum line. Flexible or incorrectly located major and minor connectors, incorrect use of clasp design, providing a clasp which is not indicated in that case, or maybe circumferential clasp is given and that is visible in the aesthetic zone. Use of cast clasps that have too little flexibility means you have created a clasp which for a very deep undercut area using the chrome cobalt alloy cast, and now it is going to give trouble. Or they are too broad in tooth coverage, so they look ugly, or they have too little consideration for aesthetics, so they are visible in the aesthetic zone. Laboratory procedures. Problems in master cast preparation, inaccurate impression or inaccurate cast. Probably the denture would be seating on the cast but is not going to seat in patient's mouth. Incompatible impression material and model material, that is going to be a disaster. Failure to provide the technician with a specific design and necessary information to enable the technician to execute the design, or failure of the technician to follow your instructions and to create the design which was provided by you, that is also going to end in the disaster. Support for denture bases. Inadequate coverage of the basal seat tissue, like in distal extension dentures. They are constructed without altered cast impression technique, or failure to record basal seat tissue in supporting form, or while taking the impression for the distal extension you have applied pressure using your fingers in the edentulous area. That could also be or even while doing the taking the impression for the relining, you have applied the pressure in the edentulous area. That is going to cause the problem for the support of denture bases. Occlusion. Failure to develop a harmonious occlusion. Dentures won't be stable and retentive, and there will be inefficient chewing. Number two, failure to use compatible materials for opposing occlusal surfaces, chances of galvanic shock because of metal RPDs and opposing dentation. They have some gold crown or something like that. Occlusal wear and tear of acrylic teeth due to restorative material on the antagonist teeth, probably unpolished or unglazed porcelain crowns are present on the antagonist dentation, so there will be very advanced wear and tear on the occlusal surfaces of the newly placed dentures, and within couple of months you will see that there will be attrition of the or wear and tear of the acrylic teeth. Patient-dentist relationship. Failure of the dentist to provide adequate dental health care information, including details on care and use of the prosthesis, or failure of the dentist to provide recall opportunities on a periodic basis. 6 months is minimum, as I told you. At times relining is done, if not at least checked, and if in 12 months relining would be required, so it should be done. Failure of the patient to exercise a dental health care regime and respond to recall. Patient, they think that now we got the prosthesis, we are good for life, they are not coming, and when they come back then their mouth is going to have a lot of problems because of not keeping with their recall appointments. A properly designed RPD, a removable partial denture, should be designed and fabricated in such a way that it avoids the errors and deficiencies listed above. Should be functional, aesthetically pleasing, and long lasting without damage to supporting structures. Removable partial dentures thus made will contribute to a concept of prosthetic dentistry that has as its goal the promotion of the oral health, the restoration of partially dentureless mouths, and possible elimination of the ultimate need for complete dentures. So over here we are done with our very important lecture on the post-insertion complaints and what considerations we should have in mind at the initial placement appointment, how we should overcome any problems if we will get, or maybe in future if patient comes back with the post-insertion complaints, short term as well as the long term. So hopefully you have enjoyed this lecture, and in case you need some more clarification of some points, you can always get back to me and I would be more than happy to address to those things. So thank you very much and have a very good